Hi, I'm Dr. Gregory Neal, reproductive endocrinologist at the Fertility Center of San Antonio, and today we're going to be describing a hysteroscopy with morcellation of a 3.5 centimeter type 1 submucosal fibroid. In the office, I performed a saline infusion sonography and demonstrated the size and location of the fibroid prior to proceeding to the operating room. When I get to the operating room, before I start the case, place a weighted speculum in the vagina, grasp the anterior aspect of the cervix with a single tooth tenaculum, and then I inject the cervical stroma with a dilute solution of putrescin. I use 10 units of putrescin in 30 cc's of injectable saline. I take 10 cc's of this mixture and inject into the cervical stroma using a 3.5 inch 22 gauge spinal needle. I typically inject at 12, 2, 4, 6, 8, and 10 and use the entire 10 cc's. I'm also very careful before injecting to pull back on the syringe to make sure that I'm not intravascular. The next step is to dilate the cervix, and I have half-size dilators when necessary. I dilate into a number 9 Hanks dilation. Then insert the Smith-Nephew TRUCLEAR hysteroscope and using saline distend the uterine cavity. A very important point when advancing the ultra blade through the operative channel is to keep the blade down the shaft of the instrument. You do not want to torque the handpiece up, down, left, or right. You want to go straight in the operative channel without any undue force on that blade. I will advance the ultra blade just to the point where I can see it. I try to go in slowly so that there's no chance that I will go in too far and perforate the uterus. So if you do it slowly under direct vision and advance the ultra blade until it's just past the end of the scope, then you know you're in the exact correct position to begin the procedure. I advance the ultra blade through the operative port and rotate until I can see the blade, and so I'll step on the pedal to make sure I see where the blade is so I have my correct orientation, and then I place the blade at the base of the fibroid at the 6 o'clock position. Right now I'm advancing straight anterior as the morcellator is removing the initial part of the fibroid. And right now I'm looking at I periodically will turn the blade medial till 3 o'clock so that I can tell exactly where the cutting aspect of the blade is, and then I rotate back to stay flush with the fibroid. I try to create an edge because then I can advance the fibroid to the edge, and the goal is to try to make the fibroid dance. And so I will keep cutting to try to create a new edge, and then we'll rotate the blade around to try to, again, get the fibroid to stay flush with the blade. Once the fibroid's moving and dancing, then I know that I'm in the right plane. The amount of pressure applied to the base of the fibroid is important. It should be a mild amount of pressure. There should not be any excessive pressure placed anteriorly or posteriorly, depending on where the location of the fibroid is. It's not necessary. The blade does the cutting, and there's a suction that applies to the base of that fibroid that helps keep the blade attached to the fibroid, so the surgeon does not have to torque that blade excessively. You just need to place it at the base of the fibroid with a very gentle pressure. There was a little blood that was noticed. The continuous flow system tends to minimize the amount of blood that is visible in the field, and the injection of putrescin at the beginning of the procedure also is very helpful, keeping the field clear and minimizing any effect from a small amount of blood that will show up. So again, I'm moving across the fibroid. I've created several edges. I'm trying to rotate, make sure I can see exactly where the cutting edge is, then stay flush with the fibroid. And then once I create an edge, then I come around, get flush with it, and head back in the opposite direction. I'm just going from one edge of the fibroid to the other. And when I get a new edge to work on, then I'm able to advance the blade to that new area. I typically will use 2,000 RPMs. The maximum is 2,500 RPMs, but I prefer to slow it down. To me, it seems to cut better at the 2,000. I've even slowed it down to 1,800 RPMs at times, but the 2,000 RPM seems to work the best. A very important point is not only do you not want to torque your handpiece, you want to keep it in the same plane as the operative channel, but you also do not want to pull or push on the fibroid while it's engaged. So once again, I'm in the middle of the fibroid, I'm advancing anteriorly, the blade is cutting beautifully, then I've created another tab or edge as I've referred to it in the previous discussion, and then I'm able to rotate the blade back to be flush with that new edge that's created, our new tab, and then it's able to morcellate that area. Then I move to another aspect of the fibroid. Here I'm going to the right side of the fibroid and then advancing medially. And again, you can see that it's kind of vibrating and moving, and again, that's the dancing term that I've previously used. So now the bottom is very exposed and I can see it very well, and so I advance the blade underneath and again stay flush, rotating my blade, verifying where my cutting aspect of the blade is. And here I'm just going from right to left, get this back edge of the fibroid since it's protruding into the cavity. So I just keep moving from side to side, keep trying to find an irregular edge of the fibroid that's created like a small tab or a small edge that I can advance the blade onto, and then just rotate to like the 10 o'clock position, go back to 6 o'clock position, advance, put pressure anteriorly. Then I've again created a little kind of a V-shaped tab, and then put that blade in the V of that piece of fibroid right in the middle of the blade, and then again advance anteriorly to remove that section of the fibroid. One of the keys is to make sure that the distension is adequate, and if your suction pressure is too high, the uterine cavity will intermittently collapse. That's frustrating, during the procedure. So I've got an excellent OR team, nursing staff that's been with me for several years, and they're able to adjust the pressure. We tend to use 180 to 200 millimeters mercury suction throughout the case. This works for most patients, but as in all procedures, it's patient dependent, and we may have to adjust it depending on what's happening during the case. The resection rate with the TRUCLEAR Ultra system is significantly faster than anything else I've used. I've used The standard resectoscope for many, many years has a disadvantage of the fragments floating in the fluid, and you have to remove the fragments one at a time to keep your field clear. And a fibroid this large take significantly longer. Besides the resectoscope, which I've used for many, many years, I've also tried the MyoSure morcellating hysteroscope, and it does not come close to having the same ability to resect the submucosal fibroids with the same speed and efficiency as I've noticed with the TRUCLEAR Ultra system. So right now I'm rotating the blade to the 3 o'clock position and pushing on the edge of the fibroid, trying to define the upper limits of the fibroid. The goal here in a minute is to try to morcellate until the fibroid is level with the endometrium. I'm going just from right to left, getting to the left lateral edge of the fibroid, rotating back to the 2 to 3 o'clock position, putting pressure. The fibroid is now protruding more into the cavity just from gentle pressure with the blade. I'm advancing into the fibroid. There's a little piece of fibroid protruding, creating an edge that I'm able to move the blade to the middle of that protruding fragment of fibroid. And at this point, I can at least see where the fibroid is attached, and can tell that there may be up to 10% or to 15% at the most of the fibroid that's actually in the myometrium. So here the fibroid is level with the endometrium. One technique that I found very helpful is I actually turn the fluid off and allow the uterine cavity to collapse and wait 2 to 3 minutes before re-expanding. And almost always more of the fibroid will protrude into the uterine cavity, and then I'm able to continue with morcellation of the fibroid and remove more of the fibroid than I originally thought I might be able to. So here I'm going laterally. I've created another fragment of fibroid that now I'm able to rotate the blade, flush, and continue to have the fibroid bounce or dance so that I know I'm in the correct plane. One of the other things that I like about the TRUCLEAR system is that I am able to obtain the entire mass of tissue that I remove and send it to pathology to be tested. The tissue is suctioned down the shaft of the instrument through some tubing and into a sock where I'm able to collect the entire amount of tissue. So I'm able to ensure that the entire mass of tissue that I remove was able to be visualized by the pathologist. So I'm slightly, a small amount of the fibroid still protruding, so I'm once again trying to shave the fibroid level with the endometrium. And then I again will typically turn off the fluid for another 2 to 3 minutes and then turn the fluid back on to re-expand the uterine cavity to see if any more of the fibroid has protruded into the uterine cavity. Again, you can see a few blood vessels, but in between, when I turn the fluid off, one of the interesting things that I've noticed is that if there has been a little bit of bleeding, the vessels will tend to clot while I have the fluid off for a couple of minutes. So I've also used that technique. If I do happen to have some blood in the cavity, and if it's not as clear as I want, I'll turn the fluid off for a couple of minutes and re-expand the uterus, and notice that don't tend to have that problem with the bleeding anymore. If there's any residual fibroid in the myometrium, and when I turn the fluid off and on several times and there's no more fibroid that has protruded into the uterine cavity, then I know I'm finished. If I feel like there may be more fibroid that has a chance to further protrude into the uterine cavity over time, I will see the patient back in 4 to 6 weeks and do an ultrasound. If it appears that there may be a submucosal fibroid, then I will do the saline infusion sonography in the office, and then we'll do a second procedure on the patients. In conclusion, I was able to morcellate a 3.5 centimeter type 1 submucosal fibroid. The total morcellation time for this procedure was 19 minutes. During the case, the distension was optimal. The visualization was excellent. There was no problems with bleeding, despite this being a very large fibroid. And when you look at the fibroid at the very beginning of the case and look at the anterior wall and see the tremendous number of blood vessels that are visible, I think it's quite impressive that I was able to remove this entire fibroid with excellent visualization throughout the case, and bleeding was not an issue.